For 100 years, the University of Leicester, its pioneering research and innovation has transformed lives by delivering local, national and global impact. And as we enter our second century, we remain committed to innovating for positive change in our society, and hence the need for difficult conversations such as this one. Just a little word about the lecture series and its purpose. It's to tackle controversial and potentially uncomfortable subject matters, demonstrating our commitment to being citizens of change and sharing our expertise and impact with the local community and beyond. So topics such as nuclear weapons to discovering more about Mars and about climate change are discussed in a candid way by subject matter experts and with an opportunity for audience participation. The idea is to begin a series of conversations that can lead to further discussions and further engagements addressing the key issues of our time. The first event in our Difficult Conversation series took place in November and discussed tackling hate. It is crucial for universities, especially in these times, to provide spaces for academic debate and discussion, so I really welcome this series of events. So to tonight's event, I'd like to introduce Turi King, our compere for this evening. She is Professor of Public Engagement and Genetics. She was part of one of the most ambitious archaeological projects ever attempted and was famed for her genetic work in the discovery and the identification of the remains of King Richard III in the car park in Leicester. Seen on our screens as a co-presenter with Stacey Dooley of BBC Two's DNA Family Secrets, Turi is committed to bridging the gap between genetics and archaeology and to the public understanding of science and research. So thank you. I hope we have a lively and informative discussion. And now over to you, Turi.
Thank you. So welcome everybody to this event. The evening's discussion centers around the subject of the menopause, which, despite it affecting half the population and being a normal part of an individual's life, is still, rather ridiculously, a bit of a taboo subject. It's also a subject where a combination of medical sexism, ageism, and frankly outdated science has meant that individuals have not been aware of or had access to appropriate health care. And it has a big impact on society. In a recent TUC survey of 4,000 women, 85% of them said it affected their working life. It can affect their health, job, and relationships. And it's also a time when rates of suicide peak. So it was why I suggested this subject. I think we need to talk about this, and that's what we're going to do today. And I warn you at the outset, it's quite likely that we are going to touch on the subject of sex in a pretty frank but respectful way. And I'm hoping we'll have a lively discussion after the panel discussion. I have got a crack team together on this subject. So they are Kate Muir, filmmaker and author. She produced that rather amazing documentary that Davina McCall did, Sex, Myths, and the Menopause, which went out last year and went down an absolute storm. She's also working on a new documentary with Davina about the menopause and the brain drain. She's also the author of a book just out, Everything You Need to Know About the Menopause, But We're Too Afraid to Ask. You can buy copies of it in the foyer. I've read it, and I highly, highly recommend it. We've got Nicola Junkin. She is Assistant Director of HR, Staff and Wellbeing and Organizational Development, who was key in drawing up and implementing the menopause policy at the University of Leicester. Samina Malek, who is, alongside being a consultant gynaecologist, she is the lead for menopause services and runs the complex menopause clinic for the University of Leicester Hospitals NHS Trust. We have got Helen Foster. Helen is a research fellow at the East Midlands Oral History Archive and has been running an oral history project around the menopause called the Silent Archive, not least because it's a topic which is so little spoken about. And finally, Jesse Matheson, currently senior lecturer at the University of Sheffield, who, while at the University of Leicester in 2017, he co-wrote with some of our academics, who have all sadly left as well, a key UK document from the Department of Education report called Menopause Transition: Effects on Women's Economic Participation. So I thought it would be nice for all of our panelists to sort of introduce themselves and tell you a little bit about themselves and why their sort of place in this discussion. So over to you, Kate.
Hi, everybody. Thank you for coming out tonight. So I was even looking at the title, Already Causing Trouble, Difficult Conversations. I think this is an easy conversation. I think this is a world-changing conversation that will change women's lives over 50 and some women in premature menopause too. I think we're on the cusp of a massive change in attitude to the menopause. I think the fact you're all here today for an evening out is a sign. I think the fact we're all talking about it here, and that it's had this explosion in the media. And I came to this through my own menopause, which was not just a car crash, but a full-on Thelma and Louise off the cliff hormonal disaster. And I thought, I'd been a journalist at the Times, and I thought, I should know about this. I should be able to Google this. I should be able to find out. I couldn't find out what was going on. And I just thought, period, stop. That's it. Never take HRT. That's what I knew about the menopause, and I think that's what a lot of women knew until recently. And then I thought, well, given what's happened to me, I don't want this to happen to other people. I really felt very strongly about that, and particularly the mental health aspects of the menopause and the brain fog, which is a huge, not properly discussed issue. So I got together with Davina McCall and a team of fantastic women, 5 of whom were menopausal, and all of whom were on HRT by the end of the documentary. And we went and made this film. And we didn't know what would happen, and it had this huge reaction. And the first night, it showed in this slot on Channel 4, and they got 1.3 million viewers. By the end of the week, there were 2 million viewers, because everybody had told their best friend, you better watch that thing. And that's when we realized we need to make a second documentary. There's so much more to say. And at the same time, I began researching in lockdown, because there was nothing else to do, deep, deep, deep into the menopause science. And that was the stuff that really shocked me, that it had been misreported, that the science was sloppy, that we had all been duped, and that there was enormous hope out there for women. So that's where I began, and I'm going off from.
Nicola.
Evening, everyone. Well, how do I follow that? So I'm a HR professional, have been for over 30 years, and I'm absolutely passionate about all things health and well-being. More recently, of course, very passionate about the menopause, and was very privileged and proud to work with our academics, including Jesse, to develop our policy, which I have to say we were the first university in the UK to develop a menopause policy. So really, really proud of that. Our policy has been a feature on a BBC television programme, and also is part of the CIPD, which is our HR professionals bodies toolkit. So really proud that we were able to implement it here at Leicester, and hopefully can talk to you about it this evening some more. Thank you.
Lovely, thank you. Samina.
Hi, everyone. I am Semina, and I belong to a ethnic group where menopause is not being acknowledged much, or not being felt as it need a help. And being a medic, seeing my grandmas, my mom, and then when I got the opportunity that I could be a menopause specialist, I got the specialist training. And then when about nearly 4 years ago, when I got in charge of this clinic, which is called Complex Menopause Clinic, I essentially brought a lot of changes in the University hospitals of Leicester in terms of generally how my colleagues feel about menopause and how can they help. So we have developed local guidelines, patient information leaflets. I got approval of a lot of medications which were not available before, including testosterone. A lot of hard work being put into it. I've been working with communities as well, so I go and speak where I can. And I'm actually a lead for undergraduate education as well for Leicester Medical School. So I teach and train my students as well. So that is like my bread and butter in life nowadays. But I'm general gynecologist for all other things as well.
Thank you. Helen.
So when I came to the university in, sorry, I'm having a blank moment, 2019, I was looking through the oral history archives, and I realised that there was a big gap around women's midlife. Oral history very much covers life stories. It covers people's lives from birth to the grave. But the area around women and what happened to them in their midlives was kind of missing. At this time, I was also becoming aware that I was perimenopausal. I was starting to, as I've just said to Nicola and Semina here, I was starting to communicate through the medium of mime because I couldn't remember words. And so I thought, right, let's gather some lived experience of menopause. Coming from a completely non-clinical background, so very much wanting to know what does it feel like for women to go through this time in their lives. So I got some funding to do a project, which was impacted very much by lockdown, but we kept going. We took it online, and very much engaging with the community, we took on and trained up some volunteer oral history interviewees and interviewers and got them to interview each other on Zoom. And we've managed to collect about 33 interviews, narratives of women talking about, very frankly, about their experiences of going through this stage in their life. Some women experienced premature and early menopause. Some women were reflecting back because they've gone through the whole process. And we also gathered some audio diaries and some facilitated conversations, so other ways of collecting these narratives. One of the things that came out of it, which I think has been mentioned already, is the actual act of talking about it was really therapeutic for people. The sharing of things, the being heard, that space to actually be heard was really valuable and a real benefit. So that's my approach, is I'm exploring the narratives of menopause and midlife as well, that whole kind of stage of life.
Thank you. Jesse.
Oh, my name is Jesse Matheson. I'm a labor economist. So I think about how people engage with the labor market, what makes people more engaged in their work, what makes them more productive at work. My interest in this subject really comes to thinking about, so first of all, how do we try to quantify the impact that going through the menopause transition actually has on women's labor market participation or their productivity within the workplace? And are there interventions, and how do we quantify the effect of these interventions that may actually improve outcomes for women at this stage in their lives? So these might be large interventions, like I would consider HRT to be a fairly substantial intervention, or they can be small interventions, like having a boss that you feel like you can talk to about going through these things.
Thank you. So I thought let's start at the beginning. Let's start with Semina here. What is the menopause from a medical point of view, and what are the sort of issues that women come to you with when they come to your clinic?
Thank you. Menopause, in straightforward, a lot of women would understand not having a period, and that could be because of so many reasons not having a period. Somebody might have a pills for contraception and stop having a period. Somebody might have an implant and not having a period. So different kind of hormonal contraceptions they take. But what it become matter that what is happening next secondary to it, and especially when the women are towards in the 4th decade of their life. Those simple stuff start bringing up the other symptoms, and that particularly the feeling very hot, like your upper body is feeling really, really hot suddenly and like shooting into your head. You feel sweating, and then you will be warm at one time and you'll be cold on the other time. You don't want to be in the bed with your partner, and you would like to have a fan on or window open. So that's common. And I have women, they say they change sheets in the night because it's drenching and everything is not acceptable. But this is one aspect. This is called hot flushes. The other one is mood changes. So first time when the woman having changes in their mood, if they don't have any previous history of any anxiety or depression, which is common. So if they have, if this is happening first time, that is quite an indication that you're probably heading towards menopause. So in simplest term, not having a period is a menopause, but there are other conditions as well, which can make a woman to go early menopause or premature menopause when it is happening under 40 years of age. And sadly, the women have chemotherapies and radiotherapies, which can bring very, very early menopause, or some surgeries when they end up, like for endometriosis, their ovaries are removed, so they straight away into menopause. Or sadly, somebody have breast cancers and they have those genes and they need removal of the ovaries. So having removal of the uterus is not a menopause. It's actually the ovaries. And as a result, there are so many factors. But if those symptoms are there, even in the younger age, it is premenopause, and it might need investigation and actually help for that.
So clearly there's this knock-on effects for the individual women, but also the workplace and the economy, as Jesse's been saying. So what are the knock-on of the menopause? Kate, I'm going to start with you, because I know this is something you've done a huge amount of research into in your book, and I found it hugely refreshing and frank and funny discussion about everything, that how it affects women's physical, mental, and sexual health, through to what we can do about it. So the importance of not just estrogen and progesterone, but also testosterone for well-being. So what have you found through all of your research? What are the effects on women of this change of hormones?
Well, we've just done a survey between you and I for the next Channel 4 program that's coming up. And although I can't tell you the results, it is extraordinary, the sort of decimation of women in the workplace in their late 40s and early 50s. They go part-time, they leave, they change jobs, or they're too scared to change jobs and stay stuck in the same job. So there is this layer of women just self-censoring almost and disappearing. And one of the things we were looking at is key workers, and 50% of nurses are over 50, and 1/3 want to leave their jobs. And who are the most important people who've been looking after us in the past 2 years, and who really, you can't just employ a 22-year-old nurse. I mean, a 50-year-old nurse will be able to handle everything. And she is worth so much. And the idea that we are just throwing these people away, and in my book I have a story about one of my best friends in London who is a senior nurse actually, and had terrible menopause symptoms, but wasn't sure whether she had a marina coil. She wasn't sure if her periods had stopped or not, and she was having hot flushes and she was sleepless, but most she was really anxious. And one of the things she was doing, she was working in the vaccination clinic and dealing with lots and lots of people with the COVID vaccination, and then going into the ladies to cry. And she just didn't know why, because she was doing a good thing. And she really sort of broke down at that time, and they were all doing 12-hour shifts. And then eventually she rang me and she said, I've gone and got HRT. She said, I've had it for 3 days. I feel great. I'm not anxious anymore. And she was transferred up to be the COVID family liaison officer on the ward, which was one of the toughest jobs in the NHS in London at that point, looking after families' kind of emotional needs. And there was someone we nearly lost. She got HRT, and really good transdermal HRT of the best sort. You don't want the old kind. On the whole, you want the new, and I'm sure Semina will tell you more about that. But it makes a huge difference. And actually just being able to speak about it again, to be able to go to your boss for the policies that you are putting in are really important. But I think, you know when menopause has landed, but you do not know when perimenopause has landed. And I consider perimenopause to be the actual kind of, evil force here. It's kind of the evil little sister of menopause. And you have no idea you're in there. You might be 40, you might be 45, you might be 47. I started getting heart palpitations. Thought I was going to have a stroke. It was just perimenopause, but I went to my doctor and they went, we'll give you an ECG. And I had a perfectly normal heart. They said, you're drinking too much coffee. And again, I took HRT, it went away, and nobody seems to know or explain these mysteries of perimenopause. And I think there's a really bad mental health moment that happens for women. And there's often brain fog, there's often memory loss, there's often that minute where you say, oh, it's that thing I'm going to shave my legs with, But that's happened to me. Razor. Took me half an hour to get the word razor. I thought I had Alzheimer's. And that's the dangers of perimenopause. But you imagine, that's funny here, but at work, if you're a doctor or you're in a senior position and you forget what prescription number you're going to give someone, it really, really matters, and that's why women sort of pull out of their jobs. So explaining perimenopause to women, that it affects your brain, your joints, your anxiety, those hormones going up and down. It's much, much more frightening than menopause itself in a way, because you just don't know what's going to happen to you every day. And it can really, really throw women off balance. That's when women tend to commit suicide. It's when they get divorced. And why aren't we talking about it? And guess what? I went to the NHS website yesterday, put in the word perimenopause, nothing came up. And I think the NHS really, really, well, we'll give them a good slapping in the film. But I mean, I love the NHS, and it does so much. But the people at the top not looking after us and not putting that essential word up on their website, you know, because that's where women go to first to feel safe, is that website. And it's really, really important we talk about that too, I think, particularly in the workplace. So that's my thoughts.
Helen, was that the sort of thing that was coming out of your oral history project? Were you hearing this kind of thing when you were talking to women going through the menopause?
Yes, there was. I've made notes because I can't remember things. Some of the key words that were coming out. One of the key things was everybody's experience is different. That was one of the things, that it isn't like a black and white. You know, everybody was experiencing different things. There was lots of talk around GP experiences and experiences with GPs, and quite often were they male or female GPs, and some had very positive experiences, some had very negative experiences. They seemed to be a real swing from one to the other. Other key words that came out was the word disentanglement somebody used, and this was a theme that was coming through, was that women were reaching this point in their lives and they weren't sure if, is that to do with the perimenopause, because I've been anxious for the last 20 years and I've been on anti-anxiety medication, but is that because of the perimenopause and various other symptoms, particularly mental health symptoms. They weren't sure whether it was to do with the menopause, and things were getting tangled up. And it seemed to also, for a lot of women, and they're in their narratives were talking about how it was this whole time of life. It was this sort of perfect storm, if you like, when for not for everybody, because again everybody's circumstances were different, but for some it was a time when maybe children were leaving home, aging parents, so lots of caring responsibilities were changing, caring roles. That whole thing about suddenly becoming aware of your own mortality, and all these different stressors were coming in at that particular point. It just felt like this big, some people were almost describing it's like this big ball of knotted up wool, and they couldn't untangle it. They didn't know, is this just menopause, or are there other things going on under here? And I think that was some of the concern, was difficulty with getting to see GPs, and obviously COVID has impacted on that, and that's been just the way it is. But actually being able to determine, is that something that I need to treat through perhaps potentially considering HRT, or is there another underlying cause? So other things coming in, like which I'm sure Semina knows far more about, things like thyroid and things like that as well, that can actually give you very similar symptoms. That those sorts of things were coming up. But yeah, the idea of everybody's experience being very different, but that kind of tangling up and that perfect storm were really strong themes coming through.
So Nicola, you see women come to you,
Mm-hmm.
and we've chatted a bit about this, about how quite often what you're doing is you're going, have you thought about this possibly could be the menopause? So tell me about that.
Yeah, so we have a really confident occupational health department who, when an individual is sitting before them, they will speak to them about menopause, and that individual may not have even thought that menopause could be the issue. So we encourage individuals to make a diary before they make that appointment with their GP, so that they're really clear what exactly is going on with them at the moment, because as we know, we've just heard from two of our panel that symptoms are very individual and very different for every single member that's affected by it, and also they transcend race, religion, socioeconomic. They have no boundaries. So The key for us is that managers understand the policy. So if you're not from the University of Leicester and your organisation doesn't have a policy, please give them my name. I'd be very happy to talk to them about developing a menopause policy, because that's the key. It's understanding what support is available within the organisation and to help an individual understand what adjustments can be made within the workplace to ensure that they remain in the workplace.
So Jesse, you've been looking at this in terms of like the bigger picture in terms of the economy, and you were involved in that major government report. So what was it showing in terms of the economic knock-on effects of menopause in the workplace? What did you find as part of your report?
So I should just lay out what the report really does. Is at the time we did a comprehensive review of all of the evidence that was out there on how menopause impacts labor market participation. And then we tried to apply that to thinking about, well, what does this mean for the UK? And so, I mean, the main finding, which will be good news to any social scientists out there looking for research projects, is the evidence base is actually not very good. There's a very weak evidence base on how this impacts labor market participation. Now, there are a few exceptions to this. So one of the exceptions is actually a paper written by one of my current colleagues right now, which looks at the impact of HRT on labor market participation. So, and in particular, they compare women who stop using HRT because of these medical scares they hear. They compare those to women who were using HRT before the medical scares became public knowledge. And what they find is astounding. So a 30% decrease in labor market participation from women who quit using HRT because of that. Now that becomes difficult to generalize to the broader population because it is a pretty small set of women, but it does mean it's having a big effect on a specific group of women. Now, once you start to look at the broader evidence, it becomes a little bit muddier, and part of that is because it affects people differently. So in fact, we found a lot of qualitative studies which were showing that actually going through the transition invigorated some women and led them to be more productive and more engaged with their work. So this is if that's happening, well, that's going to offset any women who are having negative effects from it when you look at the aggregate data. So it becomes very, very difficult to quantify. The other evidence that we did find is that for women who remained in their job while they were going through the transition, there's probably the majority of women experience negative effects in terms of their productivity. So the brain fog would be one obvious mechanism. Hot flushes would be another mechanism through which this could be happening. And here we find that, where the evidence gets a little shaky here is on, well, what can be done in the workplace to help with this? So what type of measures can employers be putting in place to alleviate and regain some of that lost productivity?
So we have a menopause policy. What's in place?
Okay, so there's a number of things that we hopefully have in place for our staff that are affected. So it may be as simple as agreeing with your manager that within a particular area of the office you sit near the window so you can have the window open. Our Work Smart Spaces, which is our space where we have hybrid working, so staff don't necessarily have their own office but can come onto campus. So we have fans available for staff to go and take to the desk that they're at. But we also encourage, so we've recently we now have a reason for absence that is menopause. So previously, if an individual was off with symptoms of menopause, then invariably the reason would be gynecology, a gynecology reason. So we've now got menopause as a reason, which helps facilitate that conversation when the individual returns to the workplace with their manager to talk about menopause and talk about the different things and the adjustments that can be made in the workplace. It's individual for every single person that's affected, so those adjustments can be tailored to their needs.
And when we were chatting, you were talking about how quite often you direct people to go and see their GPs, and I happen to have the greatest GP, and I went to go and see her, and I chatted to her about it. And I'm on HRT. I totally recommend it. So let's talk. What is HRT, Semina? What is HRT?
So basically, when women are going through the change, you have more fluctuations in your hormones. And a woman's body had a lot of hormones needed for different purposes, but particularly from the ovaries, the two hormones which are produced, the one is called estrogen and another is progesterone. The estrogen is the main hormone. The estrogen is the one which keep our skin good, which keep our hair good, which keep us upbeating, keep our whole life good for heart, good for bones, everything. Second is kind of a control hormone called progesterone, and basically that hormone is released after when a woman have ovulation, and that ready a woman to be pregnant, say it. And when we're not, the job is done. And that is the time when a lot of women have PMS-like symptoms, because you have just gone in the trough of the hormone levels and you feel like the life is shattering, and then another peak starts. So that's the natural cycle. When you're hitting the menopause, you're not ovulating every now and then, and as a result, your estrogen levels are fluctuating more vigorously, or sometimes they are more on the lower side than they are on a higher side. Hence, when you are going through this, you need something which can help you to cope with that. And everybody have their own coping mechanisms. That's why not everybody is on HRT. Some people would like to take some exercises, which just bring and increases your dopamine level, your serotonin levels, makes you happy, and so it is very, very individual way to do it. Some people are very scared of hormone therapies, so they have other things to try, and the GPs will keep giving them. But as a matter of fact, if you go on the British Menopause Society website, and they have a patient website with women health concerns, the HRT is the most important and effective treatment for menopause symptoms. Alongside, if somebody had more anxiety going on, then it is CBT, which is 75% effective. And there's a lot of help available online, which you can recourse yourself and to look at it. But technically, you need replacement of those hormones to walk through the day, and it depends upon what you do. As I said, it's very, very individual. You all cannot be treated or cannot be assessed on the same line. You might have a friend whose work-life pattern is different than your ones. You might be like my nursing colleague, being on the floor 7 o'clock, my surgery colleagues 8 o'clock, or you might have a friend who work in a supermarket in the night shift. So you can imagine that we have a different work situations. We have different kind of cognitive work that we do. We have screen jobs to do, concentration, and all that affects us really, really differently. But most of the women, when they are taking HRTs, replacement of those hormones with the body identical, now we are talking about body identical HRTs, they have found 70 to 80% improvement. Not only those hot flushes that we talk about, but also memory improves, energy level changes, your palpitations start getting better, and you found yourself more engaging with your work. And hence, that's why we talk that HRT, which is estrogen and progesterone for the woman who has not had a hysterectomy. Those women who had a hysterectomy, they only need estrogen, because the progesterone is a protective to the lining of the womb. So if we have a womb, we need the two hormones in there, which majority of the women actually have the womb.
So this was something that I hadn't heard about, and you've mentioned it already, these sort of body identical hormones. And it was something, the first thing I'd heard about was when I was reading your book. So talk to me about this.
This is really important and a very, very good news indeed. So all HRT is not the same. And the kind of HRT that was studied 20 years ago in a huge study called the Women's Health Initiative study in America, which came out with all those headlines saying HRT causes breast cancer, to a tiny percentage of women, but still. You don't need to use that HRT anymore. I don't use it, and you try not to use it, do you? Absolutely. The best thing prescribed by the best NHS menopause clinics and all the private clinics is body identical HRT. And what really, really matters, and I have read every paper on this in lockdown, and I've consulted with Dr. Louise Newson, who is a wonderful menopause specialist, is that you want transdermal HRT for a start. You want it in a patch, either a gel or a patch, and you want it through the skin so it doesn't go through your liver and your stomach. You don't have to take so much, and it gets straight into your bloodstream. And it does wonderful things that the old-fashioned combined pills, which had synthetic progestins in it, doesn't. So this stuff is made, it's synthesized from yams, you put it in, it's not going to cause blood clots because it's opening up your blood vessels. It's basically oil in your system. It's not going to cause strokes. And guess what? Over 5 years in the study they've done in France, it did not cause breast cancer. And that was micronized progesterone, which is a natural progesterone made again, synthesized from yams, an exact copy of your molecule. So it's an exact copy, whereas the stuff in the old pills was not an exact copy. And it's taken me a long time to find out this, and I don't understand why women weren't told it straight away. Why take this old HRT, which was made in that study from horse urine and synthetic progestins combined together in a pill? Why not take something that's natural and an exact copy of your own hormone? Ask any 12-year-old, and they will advise you to take body-identical HRT. It's really simple. Has that percolated the medical system here or in America or in the NHS? Are the big pharmaceutical companies still prescribing the old drugs? Are the old drugs cheaper? Yes, they are. And so when you go to your NHS doctor, certainly in Scotland we were filming, the first thing that came up was suggested as what you prescribed is the old HRT. So, and when you get down to some of the good new HRT, you get a little red light that says, please ask, we don't really want you to prescribe this. Why are you prescribing this? And so it's got to come from women up, because it's certainly not coming from the medical establishment down. And you want to go in there and ask for body-identical HRT. The other thing I think is very important about the menopause is not to sit there and let it happen to you. And we've also had huge numbers of women talking to us after the last program who've had breast cancer or can't take hormones for various reasons, or hormones don't suit them. And I think it's really important not to just sit there and keep calm and carry on, but tackle your symptoms in every possible way you can. And there are, there's venlafaxine, there's clonidine, things like that, which help with, probably Semina can tell you more, which help with hot flushes quite often. There's CBD oil, often helps with anxiety and pain in your joints. And there's a whole lot of new drugs being studied right now that might be out in 2023 called neurokinin B and phytoserms, which hopefully will work the estrogen in your brain but not in your breasts, basically. So if you're post-breast cancer, you can get the estrogen back in your brain, which of course prevents the brain fog and helps prevent Alzheimer's and dementia in later life. And I think one of the most important things I've learned over the last 3 years in menopause land is that getting your hormones back gives you long-term health. And we live for a long time. We're all going to live till we're 83 on average. Why do half of us live with osteoporosis? Why are 2/3 of Alzheimer's patients women? Because when your hormones run out, those are the sort of diseases that come in and take over. And if you're protecting your brain with Alzheimer's, and you're helping with Alzheimer's, you're protecting your brain with estrogen, and you're protecting your bones with estrogen, then you are not going to end up, in that really difficult, decrepit, bent over state, and you're going to really probably avoid the bullet of Alzheimer's. And I take this very seriously because my mother died of Alzheimer's, and I saw how it affects the whole family and people around you, and how it affected her. A really smart woman losing marble after marble every day and losing her words. And I've been to America last week, and I just met two of the big scientists in America, both women, obviously, who have been studying the effect of estrogen on the brain. And they've gone to 400,000 records of women in America, the insurance records, and the women who were on transdermal estrogen were 73% less likely to get Alzheimer's. It's really top news, isn't it? And why aren't we wait for the program to come out, and we'll get it exactly for you. But I feel we haven't been told these things, and I'm very, very angry that this cancer scare for a drug that we don't really want to use anymore is this huge cloud over all our lives when we could be having healthier, better sex lives as well.
Indeed.
With the
So
vaginal estrogen.
what do we think this is? Do we think this is about the taboo around menopause? Why is there so much sort of misinformation or misunderstanding about these sorts of things? Did you find some of this coming out with you, with Helen? Were people reticent to talk about the menopause? Is there this? It's called the silent archive.
Yes. There seem to be different groups of people. There are a group of people who are really keen to engage with menopause and then were quite happy to be vocal about it. But I did encounter people who said, well, why do we need to talk about it? You know, just get on with it. The just get on with it thing came through a little bit. And that was also messages that came through sort of intergenerationally. You know, oh, my mum didn't talk about it, that kind of thing coming through. There were a number of narratives that stood out where women were actually very actively keen to talk to younger people about it and let them know, which was really encouraging, actually. But yeah, there was almost like there was this real theme of people saying throughout these different narratives, it's good to talk about it, we need to talk about it more, we need to talk about it. But there wasn't then, well, how do we talk about it? That was one of the things coming out, was how do we actually talk about this? What do we do to kind of break this taboo down? But yeah, the word taboo came up an awful lot. It's very much seen as a taboo.
Do we find that different communities deal with it differently? So Semina, you mentioned about this. Do different communities deal with this in different
Absolutely.
ways?
I think there are two reasons, and more than two reasons. When I teach my students, I said, you would find a group of women who find menopause a blessing, and I'll explain why. And then there will be other group of women for them it succors. The women's different ethnic backgrounds have a different home requirements, I must say. There are different religious practices they do. And once they stop their periods, they feel like now they have privilege. They can go anywhere for their pilgrimages, and they are more free spirit now in that way. They're not restricted by that. So that is one aspect. Then I have I see a group of women who belong to the groups where I must say that they have conditions, like they have large fibroids, they have endometriosis, and somehow these are fed by our hormones. So once they are going through the chain, they will wait for, we give them some time and injections to create artificial menopause to help them to stop that effects of those stuff. And when they are going through the chain, they kind of, as you said, they accept as a menopause, let's get on with it, because I don't want a hysterectomy. I don't want that major surgery. It's just a couple of years, as everybody said. No, it's not a couple of years. It can be 15 years. It can be 20 years. My oldest patient is about 85-year-old. She takes HRT, and she's well enough to take HRT. So I'm just trying to say is that it's a lot which is in the communities. Their awareness in the communities is not there. You tell me if you have your show name with the Davina McCall. When the sex name comes, there are communities that will not even watch that talk because it's talking about sex in there, which is a common thing in everyone's life. So these little things need to spread to the community through the social media, through the awareness groups, that you have to accept the women in different societies are treated differently. Women from those societies don't walk through the door of NHS even clinic. This is a big thing. I don't know how they approach their GPs. I don't know GPs in those areas, how active they are. I must say, I'm working with a group of GPs, brilliant group. We have, as I said, we've done a talk for more than 150 GPs in September. I'm going to do another one in June. We are developing the Leicestershire guidelines for them. So we have like meeting every 3 to 4 weeks. So there are younger group of GPs who actually working in those communities. They are more enlightening themselves. And it is everywhere. Intensity is different. Acceptance is different. But if you give them the option, yes, you can still practice your privileges, your religious practices. I do it, so I know how important to my mom, how important to my colleagues are. But if you tell them, no, these are HRT, we don't let you bleed. after so many years after the menopause, you're taking them. And this is not a disease that you need to be worried about. It's not a disease, it's a change, and we need to help you to go through the change. So I think it's the message reaching deeper into deeper. I was talking to, there's a CamDoc UK, so I've done an international webinar with them a couple of weeks ago. And when we're finishing, then one girl said, I wish in my Cameron, can somebody make my government make a rule in there that my men can understand that.
So is it the sex thing? Is it the sex thing that makes it taboo? Because it does have a big impact on women's sex lives. Is that part of it, do you think?
I think partly women just don't want to talk about it because it's so aging, and hence the deep silence in Hollywood and in the new version of Sex and the City. But the sex thing is incredibly important, and the answer to that is so simple and so joyful, which is 51% of women BMS survey say that menopause has affected their sex life badly. And actually, at that point, you should be, raring to go, because frankly, you've got rid of your children,
the
you've got time, whatever. And the best, and the amazing solution to all this, of course, is vaginal estrogen, protecting your vulva. You can use it even if you've had breast cancer. It is a tiny amount, like worth about 1 or 2 HRT pills a year. It's a cream or a pessary or something. And it means that your vagina stays all soft and happy for years and years to come. But what really it was important to me in my discoveries was it helps stop UTIs hugely, because of course if it's all dry down there, then you're much, much more likely to get a UTI. And women in their 50s, 60s and 70s start getting more and more UTIs, and women in care homes are suffering from that all the time. What they need is vaginal estrogen, and it's something you take at 50 and you stop taking it when you're 90 or whatever. You take it for the rest of your life, and only 10% of women take it in Britain, and 80% of women get symptoms. And that is an absolute no-brainer, and it's a no-brainer for the NHS, because you imagine, you go back, I would have 5 UTIs a year. I have no idea what other people have, but it was a problem for me. And it's gone. And for women of a certain age, that is a real struggle. And it's really important. Do we talk about it? And so, yes, it's absolutely fantastic for your sex life, but it's also for the rest of your life as well. It's really, really important. You want to be able to ride a bike.
There you go. I hadn't thought about that aspect. So, Nicola, do you find that women are a bit worried about coming and chatting to you about this? Is there this taboo? Are people worried about talking about it, or do you find it's getting better? Or
I definitely don't think they're worried about coming to talk to us in health and wellbeing.
Okay,
definitely.
well, that's good.
So hopefully that's because whenever we're presenting about anything, we always manage to use the word menopause in it. So I don't think they're worried about coming to talk to us, but I think individuals are worried about talking to their manager. They don't want to start the conversation. The manager doesn't invariably start the conversation with them. And sometimes they don't even recognise that what's causing them concerns at work is menopause. So I think we just have to be open. We have to ensure our managers are thinking, when they're thinking of the conversation they have with an individual about their well-being, that menopause is talked about and mentioned, and it might not be, but it's just opening that conversation up. So,
Jesse, did you find that people were reluctant to take part in the study that you did, or did you find that people were happy to chat about it?
I mean, I would be a little cautious about drawing any generalizations about how people feel about talking about menopause from people who volunteer for a study on menopause. But one study we did come across, which I thought was really insightful, particularly when it comes to the workplace, is they asked women who had withheld information about being in the menopause transition from their employer, despite the fact they were having difficulty with it at work. And they asked, well, why did you do this? And the number one answer by far was because I didn't want my employer to think it was going to reduce my productivity at work.
Yeah.
A distant second was because I was embarrassed. So I mean, this is suggesting that there's probably room for employers to just be saying, look, this is okay. This is something you shouldn't be worried about. I'd like to throw something out there, just, from my perspective as a man on this. So when I think about, would I be uncomfortable if somebody talked to me? Now, I would never try to sell myself as a representative male. So take this with a grain of salt. The answer is no, I wouldn't be uncomfortable if somebody came to me and talked about it. However, somebody who themselves wouldn't be uncomfortable talking about it might think I'm uncomfortable with them talking about it, and I wouldn't bring it up to them because I think they're uncomfortable. So, so game theory is a big part of economics, and so you have a little game here. And what you need is something like human resources to come in and intervene and say, no, it's okay to be talking about this. Both sides just communicate. So, yeah.
So one of the things you mentioned there was productivity. So I've got one last thing, I think, before we open it out to the audience. Testosterone. That was another thing that came out of reading your book. I had no idea. So chat to me about that, and then I'm sure we'll go over to Semina with it as well in a minute.
Yes, this came as a surprise to me that the hormone we make most of as women is testosterone. I had no idea. So we make it in the largest quantity, even more than we make estrogen. And it seems somewhat mysterious as to what happens to it. So while the rest of the hormones fall off the cliff and disappear basically at 50 or 51 around menopause, testosterone slowly declines later on. But it doesn't merely help with, there's been a really interesting Australian study on testosterone in women, and it doesn't merely help with libido, which is what we'd expect, isn't it? It helps with energy and concentration and sort of interest in exercise. It helps with your kind of oomph, your daily getting on with it energy at the beginning of the day. And one of the things we've done for the next documentary, results not yet to be revealed, but we got 5 women to take testosterone for 3 months, and it was absolutely fascinating what came out, and not actually what I absolutely expected. But increasingly, you can get testosterone on the NHS under the NICE guidelines 2015, which says you can have it for low libido. You've got to go in and say to your doctor, I'm not having sex anymore, it's really embarrassing. And actually, in fact, testosterone, why is it our biggest hormone? What on earth has it been doing all this time? And why is it not part of the HRT package? Semina.
Yeah, so this is where we go to Semina and go, what's going on?
Because you prescribe it, don't you?
I do.
Yeah,
actually, I got the first approval here for our CCGs. Basically, the thing is the testosterone have a lot of resources in our body. We have 50% coming from a gland called adrenal gland, which sits on the top of our kidneys. In women, the 50% does come from the ovaries. And women who have early menopause, actually, the testosterone also fall very quickly down. Testosterone levels actually have a bit of steady fall, I must say so. So if you're 25 to 35, you have the peak levels, and then it's just like a very steady. And then you can say like about 70 to 80 years of age, you have 1/3 of testosterone left when you are 30. So it is. But when our estrogen and progesterone fall, we get that knockout effect more significantly compared to when they are playing and they are slowly falling. So this is going this downhill. But our sisters and who get the surgery when their ovaries are removed, they have very sudden effects. They would like they just being, even you give them estrogens, they have no effect on them because they're suddenly deprived of 50% of testosterone in their body. And as we know, that testosterone is, it's licensed for libido, I'm afraid. That was the only way to get the license through. But it is for concentration, brain fog, memory, energy levels. It really, really helps a lot. So it is part of a package, but because you have to give HRT first and then give. I tend to give together if it's a chance, but sometimes women are a bit reluctant, they need to read about it, so I give them leaflet. I start them HRT and then give them leaflet, read about it. We need to do some baseline tests for them just to make sure they're not coming back man next time. So energy level will be lovely. So there are there's few side effects because why I'm saying so, we don't have one single product approved for women use in the UK apart from private sector. only one thing which is there called Endrofem. It is a licensed product in the Western Australia. The private practitioners, they have access to licensing, but I'm getting the news that maybe within a couple of years, it will come on the NHS. So what we did, we get the male hormone, we quantify how much they needed, and that's why we got approval for, and that's why we can't give you the dose which men is using. So we ask you, okay, so sachet use in 10 days, they might be using 3 sachets a day. So you can imagine, we need to be careful how much you're applying, because it can result localized hair growth where it is. And if you become over-enthusiastic, you might start losing hair bit on the top, because high testosterone can result in baldness. So a little bit skin changes, but if you follow the correct dose, you don't get those symptoms.
Yeah.
That's what I tell everybody. Don't get over-enthusiastic. What I said to you, use only that much, and you'll be fine. And you would definitely, and I follow them up with the levels in a 3-month time, and I just presented my audit to the UHL and to the RCCGs, to the TAS, which is the Therapeutic Advisory Service, and we got a green signal that we can carry on with this in our CCGs. Yeah, I just got the news 2 weeks ago. So we started in 2019, the workup, and I've been told that the audit was showing that it has been effective, and it hasn't resulted a lot of people any side effects to that extent that it need to be stopped. So yes, the testosterone will carry on.
And also, why should there be huge side effects? Because if you're going back to the same amount of testosterone you had when you were 40 and you're 50, you didn't grow a beard when you were 40. Do you know what I mean? It's only if you, the problem is we should have it the right doses for women, and they give you a male packet, and you've got to work out what, 1/10 of this tiny sachet is.
Yeah.
But in fact, if you do the right amount, you're just normal, I've not got a beard so far.
Nope, definitely. So, ask questions. You have the most amazing panel of people here, and they are happy to take your questions. So please, do feel free to ask any questions that you've got. There will be roving microphones going around.
Hello. Mrs. Malek, you mentioned new HRT and old HRT. I know nothing about that. So could you enlighten me? If I went to my GP, would she know that? Would I have to prompt her?
Yeah, I mean, old HRT is, as you Kate rightly mentioned about, they was from horsemare urine. So these were called conjugated equine estrogens. Now they have been replaced with a chemical formula exact identical which your body and my body be making during our reproductive lives. So these are available in the form of a skin application, either a small patch you can wear every time, and you change 2 times a week. If somebody need more, 3 times a week. Or there are gels, different companies making a couple of gels that you can just rub it. Within 15 minutes, it dries down. An hour later, you can shower, you can swim. There is a new thing called spray now. It is even more quicker to absorb, and it is also low dose, and you can build it up. So this is the skin estrogen. Then from soya plant and yam plant, they are making natural progesterone, exactly what my body would be making. And these are they're not new, they're here for 10 years, but they're not being projected rightly. Now they have been projected rightly. The old ones are, and I think because the GPs are not well trained, they open a thing called BNF, and they look what is cheap, and they look what is easy to prescribe. It's already written, okay, within 12 months of a menopause, give this one. Within more than 12, give this one. It has 2 hormones. They sometimes don't know that which combination works effectively, and how can they improve the dose. When you take HRT in the split form, you actually can adjust the dose according to your bleeding, according to your symptom, because now you're not dependent on that package. So we have very individualized kind of treatment plans for everybody. And GP is getting aware, but it's money matters there. So now what I'm developing the guideline, when I come to that part, I want this to be on the top. I've been told we can't put this on the top on the guideline because it costs that much. So we have restraints about that.
Could I just ask, at what point, when you're taking the estrogen gel and progesterone, which is what I'm taking at the moment, when do you know to stop taking progesterone? How do you know when that's the time?
Until you have your last dose of estrogen in your life. So progesterone is to protect the lining on your womb, so it doesn't overgrow, it doesn't make tags or precancer or cancer changes. So even the least amount of, except the vaginal one, vaginal is a very tiny dose differently, but if you're using, we call systemic, which means going into circulation ones. If you're using that one, you wouldn't need progesterone until you completely stop using them.
Okay. And then the testosterone you talked about, just to clarify, is that available now?
It's available for the last 2 years.
Okay.
You need to ask the GP.
You just ask them. And then you have to have regular tests of your levels, is that
Only
right?
I would recommend first line 3 months. And then if there are some fluctuations, then after 6 months again. I run advice and guidance service for the GP. So because waiting times are long, if they put a question within 2 weeks, I answer them back, and all of GPs now, because it's AMBER, so on my advice, GP can prescribe them. So if they are not being allowed to prescribe themselves, then if they put down a question to me, you doesn't need to come to a clinic for that. Your GP can prescribe you. Okay.
Hi, I've not actually been taking any pill contraceptive for a long time. Does that impact on my hormonal levels? And I've been advised to go on the progesterone-only pill, which I haven't started yet. And equally, HRT, the new ones that you've mentioned, the transdermal, are there any reasons why you can't take that? Because I've been told by my doctor that I smoke, got to sort that. But equally, in my family, both my mum and sister have had breast cancer.
Okay. First of all, skin preparations, they are safer because if you smoke, your risk of developing blood clot is higher in your body. And as a result, if you take tablet form of estrogen, which is the main hormone, it tends to go through your liver. When you go through your gut and liver, it tends to produce more clotting factors in your body, and it increases your risk of clot formation, which can result in heart attacks and stuff. So as a result, they would say use the skin preparation, which open the blood vessels and actually reduces the risk of heart attacks. So in some studies, estrogen is rather used for the treatment. Second thing is the family history. Now, it's a very difficult area to address because you do not have all the genes in the world resulting in breast cancer being diagnosed. So there are few genes which are being studied, and once somebody have a family history, a geneticist would look at and see what is your risk of developing it. But HRT do not make your genes to work like that. HRT could be an extra factor for somebody to develop breast cancer, but HRT is not going to change your genes, make your genes to become more susceptible for breast cancer. But we say, yes, having a family history, your risk is double developing breast cancer. Having a HRT is kind of like a third risk factor in there, but it's not a contraindication at all.
Hi, so question for Kate. I don't know whether the topic of menopause is controversial or difficult, but I just feel like there's a real lack of knowledge. And when you did the documentary with Davina, it brought the topic to the forefront, and that's when I think my friends and I started going to the doctor and asking questions about it, but they weren't, I mean, I had a nice doctor, but I don't think in general their GPs are forthcoming and sort of saying, well, you're sort of at that age, you need to start thinking about this. Did you find when you did the documentary, did you find there was a lack of information in general about it?
Shocking. 41% of medical schools don't teach a module on menopause because only 50% of the population get menopause. We went, in the documentary, we went to the Royal College of GPs and said, are you going to make a compulsory menopause module? And they said, we don't have time. Menopause is in one of the GP's module, and it depends who your kind of GP leader is. If you get someone like Semina teaching you, then you're going to learn all about menopause. But if you end up in a different department, you just could end up learning absolutely nothing. So when you look in the Royal College of GP's curriculum, which I do daily, I couldn't find menopause, and then I found a section called breast and gynecology. Obviously, we seem to just have one breast and gynecology. And deep in breast and gynecology towards the bottom, I found a reference to menopause, and indeed it was there, and you should know about menopause and prescribing HRT. But really, we are suffering from an absolute wall of ignorance and people just not making the effort. It should absolutely be taught in every university, and I think in about 2 years' time, due to the Make Menopause Matter campaign, it will change. And also politically, we've got the fantastic Caroline Harris MP out there in Parliament fighting to get, HRT made almost free in England, and the new menopause task force. My only worry about that is it going to be a talking shop? Because actually what we really, really need is medical help and medical knowledge. And one of the things we did after the documentary is the menopause charity, who I also work with, we set up this course which was done by Dr. Louise Newson, who runs the biggest menopause clinic privately in Britain, and some NHS GPs as well. And we made the course free. It's about an 8-hour course. And 21,000 GPs and healthcare professionals signed up for that free course this year, which would strike me that 21,000 people felt they weren't being taught properly and wanted to do it in their spare time and really cared. And so it's really, I get the impression it is absolutely not the GPs on the ground who are at fault, but the people sitting at the top making policy who could just sort out medical schools teaching it like that, couldn't they? They could just say, in September, we will teach a module. And, there's plenty of modules around. It wouldn't be difficult. Every GP has to just do this multiple choice test on the menopause. Every GP needs to know what body-identical HRT is. And every GP needs to know how to help a woman who's had breast cancer and can't take HRT with other ways of dealing with their menopause, And the fact that we don't provide that for 50% of the population, it's ridiculous.
Hi. I just wanted to know, what would it take to get GPs on board to actually be able to prescribe a woman's HRT or hormonal treatment which they required on an ongoing basis? Because it seems like we're working against two things. We're working against a woman's life cycle in work, brain fog and everything else and what it has, and then the long-term effects of when they get older of what that can do to them as well. Wouldn't it be, I'm of the sort of like the old school of prevention is better than cure. And I know it's an old saying, but realistically, if women were given what they needed at the time, for whatever length of time it was needed, wouldn't it be more progressive and forward-thinking? Because it would help society, it would help the workforce, it would help generally everybody in your family. You know what I mean? Because I don't know about anybody else, but there's times when I've wanted to kill some of mine. You know what I mean? And it's nothing, it's just because they just looked at you. But it just seems like we talk about it a lot, but nothing seems to actually get done. We have this one crusade every year or every couple of years, but there's nothing concrete, and that's where we need to get to. How do we get to that position? I know it's a bit of a broad question, sorry, because I think it affects everything, and it affects, menopause, if women, at whatever stage you're at, it affects your life, and it affects your surroundings, it affects your environment. And that in itself, once you're going through it, it's really difficult to stop it because, I've had the brain fog, I've had the palpitations. My doctor told me I'd got anxiety disorder. You know what I mean? That was 15 years ago. I've still got the anxiety disorder, but then I'm thinking to myself, really, I'm sitting here thinking it was the menopause doing all that. Do you know what I mean? But they didn't recognise it. And she told me not to go on HRT because culturally it would cause me kidney failure.
Wow.
And that was a woman.
So you've been looking at this as kind of a social... Oh, sorry, Jesse.
Yeah, I was just going to say, I know a little bit about how these prescription decisions are made based on the NICE guidelines. And the NICE guidelines, whether something gets into there or not, is basically based on statistical significance from scientific studies. And so one of the things that would certainly help with this, so I don't know much about the medical studies that have been done on the efficacy of hormone HRT, But certainly not just the medical studies, but also showing that there's some social science studies to show that, I mean, this is really having a real impact on the day-to-day lives of women. I think that type of evidence base is what we need to really push this through and make this a mainstream or a first-line prescription, I suppose we could call it.
I know you're really campaigning on this kind of angle with the sort of work that you're doing, aren't you?
Well, it's just really cheap to help women in menopause. And when you think about it, not just at work and losing all those nurses and people who've got all that experience, but in terms of the cost to the NHS is extraordinary, Jesse. Because if you think about the kind of nice HRT that we're on, and it costs approximately £120 a year to the NHS, and a hip replacement costs £15,000. Now, I'm very unlikely to get osteoporosis because my bones are regenerating all the time because they're getting estrogen. And, you know, a year in a care home, like my mum, £40,000, £50,000 a year. So why not save that? I mean, I would love to find, maybe somebody knows an economist here. Maybe you do. I'd love to find an economist who could crunch those NHS figures and go, well, if 10% more women went on HRT, what would happen to the osteoporosis rates in the long term, the Alzheimer's rates, the workplace rates? And I mean, I really think, you know, once we explain the economics, I think you're right. It might make a huge difference.
Well, and based on, I mean, certainly just based on what I've heard here tonight, but also on the evidence that I've seen in the social science literature for HRT. I mean, this should be a no-brainer in terms of a cost-benefit analysis. But yeah, those numbers do need to be crunched. And I'm not aware of them having been done, but it's, yeah.
Loads more questions.
Just ask, and it's following on from that, but it's probably a slight tangent in terms of difficult conversations, because I guess for me I'm slightly worried about the medicalisation element of this, because it almost seems like what we're saying is everybody should have HRT, because for that perspective of Alzheimer's, you know, in terms of osteoporosis. So is this what we're saying, is that actually this needs to be part of how women are for future societies? And I'm just slightly uncomfortable about that.
I could jump in and just share some of the stories that I was listening to, because there was a lot of conversation around how menopause is just seen as this medicalised thing. It's all seen through this lens of medicine. And there are women out there who don't want to take HRT. They kind of have a more... I'm sound like I'm making a big generalisations here, but it's just trying to cover a lot in a short period. You know, some women who took a more, or have been taking a more spiritual approach to it, if you like. They look to midlife as you know, this celebration of cronehood, and they want to approach it, and they make lifestyle, you know, very deliberate lifestyle changes to their exercise, their diet, but they choose alternative therapies, and they don't want to take HRT for various reasons. So there is that sort of conversation going on about it not being so medicalised, it being seen as like, you know, it's a disease that happens to us, and I can't remember who said it earlier on. It's not a disease, you know. And I think one of the big themes that came through to me was this thing that it's not just a list of physical symptoms, it's a whole aspect of our lives that it touches on. So yeah, that's kind of the stories that were coming through to me anyway. I don't know if anybody else.
I think if you look at the NICE guidelines, it said it's individualized care, the first thing. When I do my presentation to my students and everything, so my title is individualized care. So no, it's not medicalization. It's the right people to know what is not helping them, for them to go forward and get it. So one who can do, as you said, with diet and exercise regime, there are people in the world, like if you look at Japanese and Chinese, they have diet right from the beginning, kind of more rich in estrogens. They eat tofus, which has more estrogen. They have least menopause in those societies, and they're not underprivileged societies in every part in there. compared to the Caucasian population. So there are ways to go through that, but everybody experiences it. How other people go about it, how other people reflect on it. But there are people who probably need treatment and just to get through the life, actually. It's not a luxury. And I think that's why that medicalization word come forward more, just to give that perspective to the women who probably would never come forward.
Yeah, I think it's a very important thing to think about, but I'd be worried about going too far in the other direction, and women who would really benefit from HRT are not taking HRT because maybe they're scared of the medical risks that more than they should be.
I just would like to. Sorry, just I'd like to ask about. I think Kate, you mentioned that treatment is almost free, but not free. So I just would like to understand: is HRT this you mentioned about vaginal estrogen or testosterone? Are all these treatments free on the on the NHS, or are we expected to contribute with payment?
In England, in Scotland and Wales, they're free, and in England, there's now, I think, one sort of copay, one prescription charge per year that's about to be put through, according to Caroline Harris's campaign. So it will cost you £18 a year tops. So, but it's in some areas of the country, it's very, very, not this one, which is fantastic, but it's very hard to get testosterone in some areas of the country. Lots of women pay to get it free because they can't pay for it because they can't get it on the NHS. But yeah, no, it is. And the other thing you were saying about the medicalisation, I just want to say the other thing is, having written quite a medical book and a sort of radical shouty book about what we should do and how we can save ourselves in later life, I've also come to the thing of, that I want to write another book which is about menopause as a portal. And you go through that door to the second half of your life, and what are you going to do with it, whether you're on HRT or not. You know, your family has changed, probably whether you're looking after older parents has changed, but also your brain literally does change. And I've just been in New York talking to people who've done brain scans in premenopause, perimenopause, and postmenopause, and your grey matter literally, and this is everybody's brain, in women, goes down like that. In perimenopause, it starts going down like that, it bottoms out like that, then it starts going up in a lot of women, and it gets quite high, a little bit higher. Your white matter, which is your connective tissue, the kind of connecting back to remember things, gets quite low. But your grey matter, and you start pumping more blood to your brain after menopause. And I think we turn into different people. I mean, who knows what we turn into, those of us who are on HRT? Are we getting less of that? Are we getting more of that? Has anyone bothered to study it? No. Good topic for the university. But it is really true that our brains are different brains, and we do feel different, and the way we use our lives after that, you know, hopefully for good, you know, is really, really important, and it is worth considering. What it doesn't happen to men, it only happens to us. We get a different, like our brain reboots in pregnancy, and most of us know about that. And you reboot as a person that saves people all the time with all your hands, you know, and you're multitasking. And our brain reboots again, and we've not looked into what it's doing, but we all know there's something happening, and there is this change. And I think I mean, you probably are getting the history and the knowledge, and people will start telling you about that. And what you're hearing from women is true scientifically as well as I think emotionally. But it's all kind of like, we're all guinea pigs. I don't know.
I could just add something in about the prescriptions as well, just from very recent personal experience. I went to my surgery and was charged my £18. And I had this debate with the receptionist because I thought they were going to be free, and she knew nothing about it at all. So I then tweeted Caroline Harris, and she said, "Oh, I don't know, I'll chase it up." So it's all a bit vague.
It hasn't gone through yet because the NHS computers can't sort it out.
Yeah.
Okay.
Yeah. It hasn't gone through. That's true. I had a GP who's under. So I do voluntary training for them to become specialists, and then they can train more people. So I've done 3 people trained. It's a voluntary work. And it's like 30 sessions they have to do with me. So it's a nice GP. She's working. She's very keen, and she's very uptight. She knows everything about it before even coming to the training. And I posed this question because I've seen that what has been done in the Parliament. And I said, are you facilitating? She says, it hasn't reached to the CCGs yet. So yes, it will happen. But yes, having a yes in the Parliament is very quick. But actually when monetary levels the money matters come in it takes time. But it will be a long-term thing. So don't look at the short-term outcome. It's a long-term outcome, and we should look forward to that.
Hi, this has been a brilliant discussion. I've got a million questions, but I'll narrow it down to one. So I'd like to ask a question about social media and whether that affects women's feelings of them going through the menopause, and whether it's a positive thing or a negative thing, on the basis that most of us are Generation X, so we didn't grow up with social media like millennials and Gen Z, and whether anybody's noticed an effect on it, I guess. I'm about to write a dissertation on this sort of thing, so there's a personal question anyway, but I just wondered from the expert's perspective whether social media is a positive or negative thing for women going through the menopause.
Well, it has been, menopause Instagram is massive, and menopause Twitter, but particularly Instagram because it can be very visual. And I was aware when we did this documentary that, Davina McCall has 1.4 million followers on Instagram, or 2.8 million on Twitter. And what the information we were able to put out there, and the women responding to her, and she'd be up at night after the program referring them to doctors' pages and this and that, and sending them to various websites to find out if they could take HRT forever or whatever it was. So I think this has been a huge door that's opened to women, and they don't feel embarrassed, and it's funny, and it's quite revolutionary and strong and feminist. There's a very strong feminist thing going on here, a sort of revived feminism that we, perhaps our generation haven't seen for a while. And I think one of the things that one of the people we interviewed in the documentary said to me is a woman, Karen Arthur, who has an Instagram following called Menopause Whilst Black. And she said when she'd open, 3 a.m, anxiety, she'd type in menopause, an endless grey-haired, white-faced people came up on her screen. And, the diversity of kind of menopausal faces was not seen. But actually, menopause Instagram is amazing, and even menopause TikTok. There's this fantastic doctor called Dr. Nigat Arif, who has a massive following on TikTok. And I think the younger generation are you must know her, taking her TikTok to their mums and going, look, Mum, you can do this. And so I think, I also think every one of us, I've just had so many responses where people say to me, oh, I can't do that, can I? And I go, we'll just go and look at that paper. And then they'll come back to me three weeks later and go, I looked at that paper, I went to my GP. I don't give medical advice online because I don't, I'm not qualified. But you realize that, somebody's life has changed because of a tweet. And, that what a great thing to happen to you every week, because I'm often very sick of the word menopause. And then, somebody else changes. And, every time someone tells a story, then the next person goes, that's not my story. This is my story. And then eventually we find the story that matches our story. And I think social media is doing that a lot for us. But I think it would also be great to have these kind of conversations and all go to the pub together or whatever and have shouty menopause circles now that we're allowed out.
So it's gone 8 o'clock. I think we can probably just do one more question. I'm going to leave it up to you. Sorry.
Right, I just wanted to ask about the appropriateness of some of the treatment approaches that you've spoken about for post-menopausal women. Is it different, or is it across the board?
It's the same that we said before. We as project that skin preparations for the estrogen and natural progesterone. if we talk about the postmenopausal women, but we haven't talked about the girls who develop menopause early on, and I'm talking about under 40s, and there is a big population for that. And when they come to that population, strangely, there's about 10 to 15% chance they can have one ovulatory cycle sometime in their life. So then it comes their contraception in there. What they should take. Do you need to take 2 to 3 types of hormones? Or they're happy to use barrier methods? Or they want a copper coil? So the menopause is around everything. So if I talk about the younger women who are sadly for some reason gone through the menopause, for them then contraceptive comes into it, but they are the ones who are very high risk of heart attacks and the bone thinning, osteoporosis and fractures. And when there is a fracture to the long bone on your hip, it is a 20% mortality. So you can imagine how big is that thing. So as a result for those girls, I would say yes, if they can be okay, they can have a Mirena coil because it protects the lining, give them the contraception, and they can have a skin preparations. Or if they are the ones who like to be the part of a cohort, everybody had a cycle, I want a cycle, I'd then give them the contraceptive pill if they are in the criteria. If they can use barrier methods, I would say fine, take the HRT in a cyclical way, had a bleeding every month, you're part of the cohort. You want to buy a pad or tampon or a moon cup or whatever with your friend, go ahead and do it. So there are different approaches, but the type of the HRT that we are talking about are the natural, what is similar to your body, and that is across the board the same. Yeah, they come in different preparation, they even come in the tablet form, but their availability is different. Skin preparations, as they go straight to your blood, they don't go to your liver to metabolize into toxins or non-toxins. So they're readily available for your body, and you get a very quick effect from them.
So it falls to me to say thank you so much, and Sarah's going to lead us out.
Well, thank you to our distinguished panel, and I'd just like to have a round of applause for our distinguished panel.